heard from The Economist that the world's most valuable resource, they say, is no longer oil, but it's data. And 5 of the top 10 companies by market cap, the largest companies, are actually companies built on a foundation of data. And what's remarkable, of course, is that we've seen sensors shrink so small and become so inexpensive that by next year, there will be 1 trillion sensors in the world, basically over 100 sensors for every person on the planet. And of course, what's remarkable is that healthcare is right at the center of this. Every company that never was a healthcare company or fitness company, now because there's so many sensors, now they want to be one of those. And the challenge, of course, now is that data growth is exponential. Data is growing, it's doubling every 14 months worldwide, and healthcare data is doubling every 18 months, every year and a half. It's doubling growing faster than even Moore's law. And of course, the challenge for us in healthcare is that human labor is finite. And you've probably seen there was a study that showed that there's just in the United States alone, there's a shortage of people to analyze, managers to run data projects by over 1 million different people. And of course, human efforts are fallible. You may have seen this study where they built a robot to crawl 50,000 different studies and to look for and find medical errors and simple math errors, and it found them. 13% of those studies had simple math errors that might have changed the results of that particular study. And you've heard about the reproducibility crisis in healthcare, where almost half of the preclinical studies right now can't be reproduced. And of course, at the core of much of the preventable medical error we see is some failure around thinking or something that we do with data. So how are we going to solve this gap? Right? If we tackle this with linear solutions, we will fall exponentially behind. So it's 2006. And I walk into my boss's office, and my boss says, at the time, he says, we need to produce more art. We need to publish more. He said, we've been doing a lot of projects, and we just need to get the word out. And so I said, all right, I'll write a bunch of abstracts like we did last year and about our various projects, and we'll submit them. And he said, no. Why don't you make a robot that writes medical articles? And I remember the sort of hair on the back of my neck sort of standing up as he said that, as the implications of what he was saying kind of started to sink in. And you might recall that it was in 1908 that Henry Ford started making cars. And you might remember that the first cars that he made actually weren't even made on assembly lines. They were made using a station build approach. 5 guys stood around a particular station, and they built the car from the ground up. And when the car rolled out of this building and you bought it, you better hope that you got the good team, because the quality was somewhat questionable. But it wasn't until 5 years later that they started using the moving chassis assembly line, which 100 years later we're still moving today. And this gave them improvements such as they were able to build cars in 1/6 the time. It cost us 1/7 the cost. They were able to scale the process 120x. And what one man did to build an entire engine became 84 different steps, and the men in that assembly line process were 3 times more productive. And what's interesting is if you look at this number of authors on a medical article today, it averages the same number of people as were on that station build approach back in Henry Ford's days. It's 5.5. It's as if the knowledge that we create in medicine is just like the way we used to custom build these cars from the ground up before assembly lines entered the world. And so this was our plan. Our plan was to take a medical article, and it's actually this article here, and we would identify all the different areas where a human had to do something to the data to make this particular article. And we identified 72 different pieces where we decided that we would take those little pieces of data transformation and turn them into 72 different computer programs so that it could write this article. And I remember as I started to work on this project, I started to get this sense that this might be the most important project I ever worked on. But I didn't really tell how, I couldn't really tell why, but it just felt that way. And so I worked weeks, weekends, nights, and 6 months later, I walk into my boss's office and I say, okay, here it is. And this system ran, and 4 hours later, it ran all these different workers. It generated this particular article, but it was a robot that wrote the entire thing. But what was unique about it is that it was, because it was a computer program, it was parameterizable. So this article, monthly, weekly, and daily patterns in the incidence of congestive heart failure, became monthly, weekly, it became seasonal patterns of X. And so we found, for example, a guy who, across the course of his 20-year career, had published 5 different articles on the seasonality of various diseases. And we were able to reproduce his life's work. Instead of 20 years, it took us about 2 weeks. And it occurred to us at that time that we could take that particular approach and we could run it for every single disease that was out there, known to man. And the most published scientist in the history of science at that time had published over 1,000 articles. And we thought, well, there's 10,000 diseases. We could become the most published clinicians in the history of medicine if we wanted. And at some point, we submitted a grant during this process. And we actually finished the project before the grant we got the grant review back. And we were very excited to see how excited they were and how interested they were in this sort of technology that we had built. And I remember opening it up and reading the first sentence of the reviewer's comments. And the sentence began, wishful thinking and fluffy logic. They said it was easily the worst grant they had read in 15 years of their reviews. Well, we took that grant, we polished it, removed everything about automation, tried to make it sound like, well, the humans were doing a lot of the work, resubmitted it to another government agency, which then funded it. So that took away a little bit of the sting. But right in the middle of this project, it got paused. And the reason it got paused was because Microsoft acquired another project that we were working on, which was a massive data aggregation system in healthcare. And I remember at the time feeling like we had this magical technology, and we were putting it in a crate, kind of like at the end of Indiana Jones, and putting it in a warehouse where it might sit and might never, ever see the light of day again. But 10 years passed, and we began working on another project. And one day, as we were working on the project, we suddenly realized that the technology we were working on could be reused, and we could resurrect this previous project that we'd worked on. And one of the reasons why it was possible is because the world had changed in these 10 years. So for example, that massive data aggregation system that we had built that covered, it covered 10 hospitals going back 10 or 15 years. Every drop of data took 200 servers to store it. But now, we lived in a world where we had tools like Google BigQuery. Google BigQuery is a petabyte-scale database in the cloud, which means that we could not only store every drop of data from those 10 hospitals, but 100 times that. Just to give you a sense of scale, if you were to take all of the data, just the text data, not the image data, from the 150,000 hospitals, 140,000 hospitals worldwide, just the text data is about 500 petabytes. What that means is we now live in a world where a 17-year-old could download and store all of the world's healthcare text data in their own database to work on it. And they could do it from their bedroom or from their garage and create innovation. And there were other tools as well. This is the world we live in now. There were tools like Kubernetes. Kubernetes is what Google uses to scale. They create 3 billion virtual computers every single week, and then those computers disappear as if they never existed, and in order to deliver the different services they have out there. Or maybe you've heard of Jupyter Notebooks. If you want to learn data science, this is one of the best ways to learn. The largest data science competition site in the world is at Kaggle.com. It has 2 million data scientists, and they have taken all of their best tools, their tools that the data scientists use to win these contests, and they've put them into a Jupyter notebook that you can download, and then you can redo those data science competitions and learn it. And there's companies like Netflix that used these Jupyter notebooks and automated them into assembly lines, which meant that we could take these technologies and build something that scaled like Google. We could analyze like Kaggle, and we could automate like Netflix. We could essentially create a system that did robotic process automation, but for real-world evidence generation in healthcare. And it kind of looked like this. We worked with MedStar Health in Washington, D.C. with Mark Smith at the great MedStar Institutes for Innovation. And we essentially built a system to extract data from the electronic medical record. And then that data went to this big assembly line where these workers would go and change that data and transform it. And what would come out were these medical articles. But instead of 4 hours to generate a single medical article, now with these new cloud technologies, we could generate a new article every 7 minutes. Basically faster than we could even read them to know if they were valuable or not, which meant it didn't take 20 years to reproduce what that guy's work does, is that now we can do it in about 30 minutes, all of his work. And this is what some of these assembly lines look like. And we call them data factories. And you can see that we started building other articles, other data factories to do other classes of analysis too. And this is some of the articles that those computers, those data factories generated. And you can see they generate the p-values, and they generate the graphs, and they generate the charts. And you can see afterwards the human goes in and types all that data in green. They sort of analyze it and add their contributions. If Maslow's, at the top of Maslow's pyramid is self-actualization, now we kind of believe in this concept of data actualization, where you have this data lake and you write every possible article that could possibly be written from that data. And you can see that seasonality article, we ran it for disease after disease after disease. And you think about our medical specialties, right? We have all these medical specialty registries all over. And we could have data factories that essentially plug into these registries and just generate almost entire journals, right? Every single procedure, what the trends are, every single disease, what the trends in those diseases are. We could actualize the data that's in those registries. And what's interesting about this sort of data factory approach is that these are living articles. And what I mean by that is the article is connected down to its data lake, which means as the data lake refreshes, the article itself updates. So think about it. So you've all heard of this sort of rise in multi-drug resistant UTI, where young women are now getting complications we haven't seen in 100 years. And notice how many articles are being written on drugs of choice for different areas of the world. Germany, Nigeria, another one by Denmark. And yet, if we were to build these articles as a data factory, there could be essentially one template. And every single hospital runs that particular drug of choice article, and it generates it so that it is personalized and real-world evidence just for your particular practice. It's always current. It's always up to date. How many people have heard of FHIR out there? How many people can say what those letters stand for? Here it is here. I had to look it up too, don't worry. It's the Fast Healthcare Interoperability Resource, and what it really means, what you boil it down to, is it means that every piece of data in the electronic medical record gets its own web address. So if you go to a browser and you type this web address, then you get this blob of information back. It's not really meant to be human readable, it's meant to be computer readable. And you might have heard we used to use a standard called XML often. Now the hot new standard or hot standard is sort of JSON, and the difference between those is XML, we used to always have to parse it before the computer could use it, whereas JSON is already in a format that the computer can use. So you'll see a lot of talk about JSON data. But the bottom line is that it's supported by most EMRs to some extent. They are reluctantly moving forward and adding it. But what it means is that, think about it. You can build a data factory that connects over FHIR and pulls all the data in a standardized way from a hospital, writes an article on, for example, drug of choice for UTIs, and then most importantly, that article can then be consumable by the electronic medical record to guide care. We can finally close the loop on discovery to actually translation to the front lines of clinical care. Think about it. Today, articles are as dead as the paper on which they are printed, but tomorrow, all of our medical literature will be woven into the fabric of care as we generate knowledge, and that knowledge is translated to the front lines. And think about how this, in fact, impacts operations. We've always had this big rift between research and what operations are doing. But now, let's say you write an article and let's say you're trying to assess whether you can decrease multi-drug resistant UTIs in your hospital or bacterial resistance in your hospital, and you have some sort of intervention. Well, now you write an article that assesses it. You have a data factory that writes an article, and now you try another intervention. You just click the button and run the article again. And you do another intervention. You click a button and it creates another article, and you just compare and see if your improving. It's localized. Or think about our Apache scores, our Apache 4 scores, or our SOFA scores, or our SAP scores. Apache was written 13 years ago. It was based on 45 different hospitals. And chances are it wasn't your hospital. No wonder we are reluctant to tell our patients or try to prognosticate what their mortality risks are when our tools are 13 years old and based in hospitals that might not be our own. But imagine if we built Apache as a data factory. It would plug into your data lake at your hospital, generate an Apache score that is relevant to your particular practice, and now we could suddenly feel safe about these mortality predictions for patients. And you probably heard, N of 1 studies have been called the ultimate strategy for individualizing care. But who has enough biostatisticians to run N of 1 studies on all of their patients? And yet, think about it, if we build data factories now, these can be run as N of 1 studies on every single patient. They can be automated, and you can generate articles that are relevant and easy for the doctor to read quickly, and other articles that are in layperson words, so the layperson can read about these things. And you heard Neil talk about all the different forms of AI. Well, the latest data factories we've been building build not only AI models, but also build an article saying how good that AI model works for that particular hospital. Think about it. We could have data factories that we just move from hospital to hospital. They build machine learning models and evaluate them right there. And what's important about this is it suddenly moves us from this world of custom build approaches where now we suddenly have assembly lines. We've always had continuous quality improvement. Now suddenly we can get continuous research improvement where our approaches get better and better, and we can start to chip away at this reproducibility problem that has made 50% of what's out there, we don't know exactly what part isn't true or not, and suddenly we can start to know what's true. Just to put an exclamation mark on this automation principle, who is the fastest growing software company in history? I'll give you a hint. It's not Google. It's not Facebook. It's not Twitter. Good guess, Salesforce. I'll give you another hint. It was set in the last 13 months. I'll give you another hint. It's a Romanian company. It's a company called UiPath. What does UiPath focus on? Robotic process automation. And of course, it is our time now to bring robotic process automation into our knowledge discovery process in healthcare. And one of the biggest opportunities coming ahead, I think, in terms of data automation, is in new forms of data that are emerging. I'll just give a couple examples. So one, think about the self-driving car world that we're stepping into. This is the Velodyne LiDAR system on Google's car. It collects 9 million data points every single second. And a single driverless car has 3 LiDARs, 5 radars, and 8 cameras, which means that just one car every day collects the equivalent of 1,000 movies. The result is this. This is real data. This is something that actually happened. One of Google's cars was driving, and it stopped for a baby duckling that was being chased by a woman in an electric wheelchair. And think about it. This means that your self-driving car one day may pick up someone else's car accident, right? And imagine you're the trauma doctor. You'll receive that reproduction, and imagine getting this 3D reproduction. You'll decide whether to send what surgeons based on what you see as far as that particular accident goes. Your car may see disasters. Your car may pick up crimes, and that data may be shareable. And these sensors are now moving into our phones as well. This is the Qualcomm Snapdragon chip that's inside of our tablets and our phones. And notice it picks up a 3D point cloud. And notice that Nike announced that they're releasing an app that uses that chip to scan your feet so that you can, it will scan your feet within 2 millimeters of accuracy so they can deliver you the perfect fitting tennis shoe every single time. But of course, what this also means is we can use this in medicine to, for example, quantify body shapes and medical edema. This is data that we will have. But remember, it's not so much the data that matters often. It's the metadata we can extract. You heard from Neil's talk about how we can extract any image, look at it, and tag it. But notice that we also are beginning to be able to recognize behaviors. This is an AI. It's watching, covering something with something. You're uncovering something. You are folding something. This is AI watching the video and determining what the behaviors are. This is going to be new data that we have. It's said that some governments are concerned when driverless cars come, they won't be able to ticket. How will they get money? How will they get revenue? And of course, maybe you've seen China is now giving instant fines to jaywalkers by SMS message. Some people believe that we're moving from a world where we will get traffic ticket revenues. Instead, it will be behavioral ticket revenues is what the government will get. And you may have heard iRobot, the robot that sweeps your home, they're putting those 3D chips inside them, which means as the robot sweeps your home, it's going to pick up the 3D confirmation of your home and even the behaviors of the people who are in the room. How soon will it be before the first robot calls 911 and says that it's found a patient down? Right? Someone in diabetic coma or something like that. We are moving from an internet of things to an internet of people. And the last thing I'll just say is think about the first day someone puts on one of these augmented reality headsets that all these companies are working on, like Apple. They will be able to augment their world either lightly or they will be able to augment their data in a hyper-saturated way like this. But in order to do this, every single pair of glasses is picking up a 3D point cloud of the world as someone walks through it. It's picking up the video. It's picking up the audio. This means you will have more data in terms of your patient history and what led up to their illness than at any time in human history. How will we handle this deluge of data that is coming to us? I believe the answer is through automation. And my grand challenge to medicine today is that our next challenge is to create the first living articles in medicine. Our challenge is to choose what those first articles are so that we can begin to solve this reproducibility crisis that's been undermining knowledge and remove these preventable medical errors that have been plaguing our specialty. So the takeaway is, if you've got data, find labs like ours, and let's build factories. Thanks so much for your kind attention.
Good question. Super quick question. I mean, this is all sort of mind-boggling. You think we'll basically have a LiDAR for real-time healthcare? It's gonna.
Yes, I think that your massive skill is bringing those metaphors, and I think LiDAR for healthcare is a great way.
Right, it'll see the accident ahead of you and report it before you even know it's there.
Yeah,
Great.
absolutely.
Thank you, Dr. Gillam.
Great, thank you.
All right.